Well, welcome to this session. I'm Dr. Patrick Huang from Taiwan. Will be the chair of this session. This one is dedicated to, well, the EBD HIFU RF from energy to outcome and what will actually deliver result. And it's my honor to co-chair with my big brother. This also the big name in Thailand, Dr. Ronit Horn, Paiso Ronit Horn, well, my big brother. So that we'll chair this one together. So
yes, we will start with Patrick. Also, everyone knew him as a big boss in Taiwan. And he conducts many international courses and lectures worldwide. So he will talk about the facial contour changes and fat loss concern after RF needling, primarily three-dimensional observation from Taiwan. So please welcome Patrick.
Oh, thank you. Oh, no. Yeah. That I can, oh no, should be, can you do it again? So the talk, I'm Dr. Patrick from Taiwan, and this talk actually I delivered at AAD this year, annual meeting in the States. So, okay. So it's a real pleasure and honor to be here to share what we found in using RF microneedling in skin tightening, and also I also doing a lot of facial contour with RF microneedling. So it's the time to know that why we deliver this talk in the U.S. because in the U.S. actually a lot of patients actually treated by nursing practitioner and got atrophy, fat atrophy. So this is the reason why I delivered this talk in the US. So today I will talk about a paradox in RF microneedling. So we are very good at remodeling the dermis, but are we also damage the fat underneath? So when tightening become melting, there will be a risk to get a sunken face. So today I'll be sharing my preliminary three-dimensional observation on facial contour changes and the concern of fat loss after RF microneedling. Here's my disclosure for the past year. So across Asia, there are definitely regional differences in facial characteristics, but one feature we see quite constantly is a wider face. So in Asian patients, heavier soft tissue and wider mid-face making sagging the dominant concern. So clinically, we're dealing with a heavier, wider face with descent, and this is not easily improved by thread or filler alone. So Western strategy focusing on mid-face projection, the strategy focusing on mid-face projection, actually, but in Asian, the main concern is often the lower face. So adding volume to create lift may unintentionally make the face wider, leading to overfilled appearance. So 2 years ago, during this face study I conducted, doing with RF microneedling, I noticed something interesting. Why did this subject show such a dramatic improvement in the nasolabial fold? So we know histologically, RF microneedling does more than improving skin texture. The controlled thermal effect from the RF system may also affect the underlying fat layer. And when used strategically, this becomes a tool. So not just for skin quality, but for contouring in Asian patients. However, in recent years, there have been increasing reports of fat loss after treatment. And these two images from online resources illustrate what may occur in some patients. So the question is, why does this happen? In October 2025, in the US FDA issued a safety warning on RF microneedling. Reported complications include burns, scarring, fat loss, disfiguration, and nerve damage. Like Icarus, when we push too far, whether in depth or energy, benefit can turn into harm. What rejuvenate one patient may cause volume loss in another. So while we pursue rejuvenation, we must avoid unintended volume loss. So this is actually not new. My friend, Dr. Giri Munavari, was one of the first to show the bipolar IF microneedling can induce both thermal remodeling and fat reduction. So likely through a combination of neoelastogenesis and neocollagenesis and the partial adipose tissue destruction. So IF microneedling is often described as a safe procedure, and it can even be performed by non-physician provider under supervision. But that definition of the safety is largely based on superficial treatment. Once we move into deeper level, especially with IF microneedling, we are no longer just treating the skin. We may also be affecting deeper structure. So the key question is not just about safety. Depth, energy, and what we're really targeting. So I chose bipolar IF microneedling with both insulated and non-insulated needle to better confine the heating zone. However, the limitation of this technology is that treatment parameters are highly device dependent. So different systems use different settings, and currently there's no standardized guideline across devices. So in my practice, I use a bipolar 1 megahertz RF system. Suppose delivery allows controlled thermal effect within the dermis, extending into the subcutaneous fat. So as conducting time increase from 20 to from 2,000 to 200 to 800 milliseconds, both peri-electrode necrosis and also inter-electrode thermal spread become more pronounced. So importantly, IF energy preferentially distribute into the deeper dermis and the subcutaneous fat due to lower resistance and contributing to its contouring effect. But this is also what makes it a double-edged sword. At deeper and the wider setting, it may begin to behave like the monopolar RF. So since today's focus is on facial contouring, I won't go into too much details on skin quality, but if you are interested, feel free to scan the QR code to access the latest paper we published recently. So we compared IF microneedling alone versus combination with exosome, and both approaches improved wrinkle texture and pore size with some difference in selected patient and specific situations. So before deciding on our treatment strategy, we need to understand the skin thickness in different areas. So if the energy is delivered too superficially, there will be the risk of unwanted epidermal damage, like in this patient. So depth selection really matters. So in addition, we know that the thickness of the superficial fat and the smooth can vary quite a bit. So when we targeting different layers, anatomy becomes absolutely critical. So from this figure, once you understand the depth of each layer, it becomes much easier to select the appropriate needle depth for your insulated tips. However, it is not that simple. We are treating aging face with very different patterns. Some areas, for example, infraorbital fat, nasolabial fat pad, and the lateral part of the medial cheek fat get thicker with age, while others get thinner. So in heavier area, you can treat more aggressively, but in the thinner area, you should reduce the energy to avoid unwanted volume loss. So we use objective 3-dimensional imaging to quantify the changes. So the first 3 cases were treated with insulated needles, and the last case with non-insulated needles. The first case is a 53-year-old female who is my friend and also a soprano. And this is a very typical East Asian pattern, not a deflate type face, but a thicker, heavier, soft tissue pattern. So instead of volume loss, we mainly see tissue descent and heaviness. So with this approach, you can clearly see contour improvement, especially in the lower face on the post-treatment image. So before and 6 months follow-up, just only 1 treatment. This is So at 6 months, volumetric analysis shows around 5 cc reduction in each cheek and the chin. So overall, more than 15 cc of volume reduction after a single treatment. So the yellow area shows the decreased projection with up to about 2.3 millimeter of reduction. So this is a 46-year-old patient shown here before treatment and at 6 months follow-up. So she had a relatively round face, suggesting more pronounced fat compartment. So even after treatment, some cheek fullness remains. So likely from deep fat layer that are harder to reach in one session. But you can see improvement in the lower face, especially in sagging. So we didn't treat the mid-face aggressively, so not much change there. So instead, we focus on the lower face, and you can clearly see improvement under the chin. About 27 cc of volume reduction with up to 4.3 millimeter decrease in projection, so showing clear contouring. So the question is, can we treat thinner face? This 39-year-old patient was someone I initially hesitated to treat. I told her that your face is already small. Why do you need treatment? But she felt that her contour was a bit loose. So at first, it sounded a bit like over concern. So may even borderline obsessive. But if you take a look at the oblique view, so you can clearly see the contour improvement. And this tells us something important. Asian patients are often very sensitive to their facial shape, especially from this angle. So you can see the contour is much sharper after treatment, especially the submental area, just only one treatment session. So in the end, I understand why she wanted treatment. So even thinner patient can be treated, and the key is control. So if needed, you can focus more on area like the Mario lines, but be careful, over-treatment can easily cause hollowness. But actually, the patient came back again, saying that she wants another treatment. So this time, actually, I did again, and very, very conservatively. So this is the last case I would like to share today. And here's the male patient with long-standing rosacea with only partial improvement from oral treatment. So in addition to pulse dilation, I explained that RF microneedling can improve redness while also enhance skin tightening and fine wrinkles. So he chose this approach. In this case, we used a non-insulated needle to target rosacea, skin firmness, and contour. So after treatment, you can see tightening, especially in the lower face. So, and from the oblique view, there's a clear reduction under the chin. So also the submental fullness improved, and the one session may not be enough for sagging in the old patient. So about 20 cc of fat reduction, and lower energy in the mid-face and higher in the lower face. And interestingly, the rosacea also improved a lot, just only after one treatment, which is more effective than pulse dilators or any other kind of energy-based devices. Actually, very effective. So because of time limit, actually, I just would like to point out how I think. This is thinking of this as a 3 grade of the control thermal point. So actually, that when you treat the patient, you have to think about each single point, what you would like to deliver. It's higher, lower, and also you have to figure out the depth. So that actually, that's RF microneedling, the general perception is good. And even FDA warning, that most people can feel this one works so well. So in Asian patients, actually, contouring is just as important as improved skin quality. So when we often perceive as a tightening, may actually reflect some degree of fat reduction. So which make the double-edged sword. So to avoid complication, accurate assessment and a solid understanding of anatomy are essential. So at the end, precision is everything. And because of energy delivery is highly dependent on depth and the parameter. And thank you so much for your attention. Thank you.
Thank you. Thank you very much, Patrick. We will keep the question at the end of the session. So our next speaker will be Dr. Atinut Duangkeo, dermatologist from Thailand. She has 19 years of experiences in aesthetic medicine and anti-aging. She's the director of the Levi's Clinic and care for leading brands such as Profilo, Nivea, Endymed, many companies. Since she enjoys sharing her knowledge of the toxin, fillers, thread, and energy-based devices. So please welcome. Dr. Atinut will talk about the enhancing monopolar RF tightening through bio-revitalizing priming. So please welcome Dr. Atinut.
Thank you so much for your kind introduction. We've been tightening skin for years, but there are so many different in the clinical results. Today, I'm not only going to talk about the device, but I'm going to focus on the physics. Because in the radiofrequency skin tightening, the precision is not only about the energy, it's also about the skin impedance. And that's what I want to mention today, to combine the using of injection bio-revitalizer skin priming before doing the monopolar radiofrequency. I'm Dr. Atinut Dongkyaw from Thailand. Sawadee ka. And this is my disclosure. This lecture is no sponsor. In our face, we have 5 layers from skin to the bone. Today, I will focus on the skin and the smash layer. When we age, in the skin layer, we lost of collagen and elastin. Elastin we lost about 35%. Also reduction in the density and amounts of the 3D fibrous network that we call retinacular cutis, or the RC. It had loss of elasticity and strength that result in soft tissue damage and musculofacial laxity. In this paper, they do the study in compare between the mild sagging patient. You can see the higher density of the red line that indicate the RC compared to the severe sagging or the older patient. They have less density of the RC. That result in the sagging and loss of elasticity, and the aging appears. And this is where the monopolar radiofrequency earns its place, because we know that the monopolar radiofrequency can create the deep bulkhead. So it can help with the retinacular cutis to have the contraction, and it can reverse the inferior migration of any fat layer. And to get that result, we need to hit the subcutaneous target to the temperature about 65 to 85 degrees Celsius, while we still want the surface temperature no higher than 42 to 43 degrees Celsius. That's why we need the impedance matching. Let me introduce a little bit about the impedance matching. It depends on hydration, on body size, on maybe the tissue composition. Compare between the age or dry skin on your left side. When we do the energy-based device, it will scatter. Less of the energy can deliver into the deep cutaneous tissue, but for the well-hydrated skin, all of the energy can deliver deep down into the layer that you want. So this is why I use the concept of skin readiness with these 2 pillars. The first one, I need the skin to have increase in the physics or the energy conductivity into the skin. And the second one, to prime the skin first with the injection, it can increase the biological or priming the skin fibroblasts to be active before we are going to do the radiofrequency. And in this presentation, I frame the treatment into 2 phases. First, I do the injection, and then I do the monopolar radiofrequency. So, I will walk you through the material and method that I use. I have 20 patients between the age of 40 to 55 with the skin type 3 to skin type 5 with these or exclusion criteria. And for the energy device, I use the monopolar radiofrequency 6.78 Hertz with 400 watt. I use about 400 to 600 shots per one patient. And the injection, I use the composition of fragmented HA combined with amino acids and antioxidant, total 5 cc. For me, the ideal radio frequency, it should have the good efficacy. So the one I use, it has a bigger tip, 5 square centimeter, with the safety because it has STC, and it's very comfort because it has 7 cooling pulse. And for the injection, for the non-cross-linked hyaluronic acid, it can give the skin more hydrated, so enhance the conductivity of the energy. And with the antioxidants, it can help to prevent from any reactive oxygen species that might cause during or after doing the thermal treatment. And for the amino acids, we know it is the backbone of the collagen production, so it can fasten or accelerate the collagen remodeling. So I divide into 2 groups. The first group, or group A, the prime skin group, I use the injection of biorevitalizer priming into the superficial dermal layer. You can use cannula or you can use the sharp needle, depends on your preference. And then in the next 2 weeks, I have my patient to do the monopolar radio frequency. And the other group, I use only monopolar radio frequency without the injection skin priming. And for assessment, I use both objective data and subjective data. I use the facial laxity scale, I use the 3D, I use the skin hydration and laxity measurements, also with the pain scale and GAS. And here's come the result. There is no difference in the pain score. The same group report about only mine, no more than 3 out of 10. And here, for the biological response, you can see the red, the green line indicate the prime group. In the prime group, improve in both hydration and elasticity, better than the group B or the monopolar radio frequency alone. And from the FLR score, facial laxity score, in the treatment group of group A, it had better improvement. Reduction of the FLR score from 5 to 3, compared with the monopolar radiofrequency treatment alone, reduction only 1 score. And for patient perception and satisfaction, about 80% of the prime group, they report in much improved. Okay, so let's take a look at the picture. This is case number 1. She is a Thai female in her 56 years old. She has the skin laxity, poor skin texture with the solar lentigen and pigmentation, and also she has the loss of jawline definition. In this case, I do all of the 3 cases I'm going to share you is the prime group. All of them. So after I inject the biorevitalization priming 2 weeks, I do the monopolar radio frequency. In this case, I use 600 total, okay? And you can see improvement of the jaw formation. And from the other angle, you can see this is about 4 months after doing only 1 single treatment of monopolar radio frequency. Jaw formation, nasolabial sagging improvement, and the other angle here. And you can see also from the color mapping that reduction in the, I will show in this one, reduction in the yellow area indicate that they have less volume there. With monopolar radio frequency, we can reduce the subcutaneous fat that is too much, and we can lift it up. Okay, and this is the case number 2. She is Thai female in her 41 years old. I did injection, the biorevitalizer priming, and then using the monopolar radio frequency. She has better shape of the face, okay, the V shape, and look at this side, because in this case she focused on the submental sagging. So I do concentrate on the lower face for her, and she is very happy with the result. Sharper jawline you can see here, and from the other view. And her skin quality is also much better, as you can see. Reduction of the acne scar, and also improvement on the pore side. Again, from the color mapping, reduction in the facial volume. Okay, and this is the last case. She is a Thai female in her 38 years old. She also concerned of her submental area and jaw formation. I did biorevitalizer priming, and this case I used only 400 shots because her face is not that big. Okay, and this is the result before and after. You can see much improvement of the submental area. And in this case, with the injection, you can see that she also has the improvement of the skin quality. Her acne has been much better. Better texture, better resilience, and more responsive of the dermis. So my takeaway home message is that, first, for the radio frequency, it's not only about the device setting, but also about the tissue readiness. Second, the biorevitalizer priming can improve the conductivity, so we can have the uniformity of energy distribution. And third, from this trial, they have much better improvement in the hydration, elasticity, and laxity improvement, also with the patient satisfaction without increasing pain. In conclusion, I think when we want to optimize skin tightening, we should not only ask how much energy to deliver. We should also ask whether the skin is ready to receive that energy or not, because great skin tightening starts before the energy begins, and that's my contact. Please feel free to ask any question there. Thank you so much.
Thank you so much for Dr. Atinu's wonderful presentation. So because of time limit, let's invite our co-chair, Dr. Python Romanithon, to deliver the talk about optimal outcomes combined fractional RF microneedle plus PLLA for facial rejuvenation.
Good afternoon. Thank you for the kind introduction. My topics today is optimal outcomes combined fractional RF microneedling plus PLLA for facial rejuvenation. This is my disclosure. So as we know, the principle of the fractional RF microneedling is the contact and the needling going into the skin RF emission and cause the heat denaturation and coagulation of the tissue. We can combine the fractional RF microneedling plus injectables because the fractional RF needling causes the heat stimulation. And for the injectable, that is the chemical biostimulation. We can combine the treatment with the many kinds of injectable that we have already tried with firstly PLLA, second PDLLA, thirdly we have the HA plus glycerol and also some polynucleotide. The principle of the fractioning needling, as we may know, we should not concentrate or stacking the pulses or causing the wide damage of the tissue. So it should be very multi-level of the coagulation, slowly in the dermis and maybe down to the subcutaneous tissue. We have both the insulated and non-insulated needle. Mostly, if you are going deep, we prefer the insulated needles. But in some of the case with the superficial, if you want to treat some of the pigmentation, melasma, the non-insulated is another one that we can choose. There's a study, the efficacy and safety of using the non-insulated microneedling RF alone versus in combination with the polynucleotides for treatment of polyorbital wrinkles. And you can see the non-insulated device combining treatment is safe and provide a synergistic effect on periorbital wrinkling. This is by the photo from the VCR calculation. But finally, for any like a very detailed or very scientific based result, we need to have some like a clay measurement by the scanning microscope, which is very difficult. The combination of the Q switch and the YAG laser with the photoacoustic technology in combination with the PN also, that is a kind of one case report that after the injecting and doing the Q switch, there will be the combining of the Q switch and the YAG with the PN show promise for enhancing skin health and the quality of the skin appearance. Microneedling for the skin rejuvenation, the bridging of the photo assessment, they study in 38 female women, and they conclude that the result among all the parameters, I'm sorry for that, missing. So now to the clinical and histological evaluations of microneedling for treatment of the skin fine line and laxity in the Korean. There are also 15 cases of this study, and they conclude that the temperature control bipolar microneedling is a minimally invasive treatment options for consider of the facial lines and laxity via neo-collagenesis, as Patrick and Dr. Atinut has already shown us. For the protocol, there are many types of the fractional RF microneedling in the market from US, from the Korea. This is the one I'm using, is the double pulses. So the needle going into the skin, and on the way they are withdrawn from the skin, they will fire 2 pulses on different layer of the skin. And we are using is mostly is 25 pins with the insulated needling. The dual energy, they have 1 megahertz and 2 megahertz. The 1 megahertz is for deeper penetration. 2 megahertz is for the more superficial lesions. And for the combination, I'm doing both. We can do the injection with PLLA before, and then continue with the fractional RF needling. So the level of the skin thickness, as Patrick showed us, we are setting as a 1.2 to around 2.5 mm for the fractional RF. So it's still into the dermis and a little into the sub-Q. For the biostimulator, this one, we are using the PLLA. So we prefer to go, it is particles. We have to go a little deeper, subdermal or even the subcutaneous tissue. We have several brands for the PLLA available in the market, the product OSPIST. But mostly it's the PLLA plus CMC and mannitol. The size and flaking shape of the stimulation is also different. The one that I'm using for this study is the product O in the market. So this is the case that I started with injecting the PLLA first. I'm going a little bit very fast. So we're using the entry point with the lidocaine, and then go 5 layers, 5 line to the jowl, to the nasolabial fold, and withdraw, going slowly. In terms of the technique, it might be a little important because we have to scatter the PRA product homogeneously. Otherwise, it will form the clump or like a kaha also. If you use that, it is a particles. So in terms of the particle, we have the late complication quite a lot. And after the injection, you have to mold more rigorously in order to scatter the product evenly over the cheek. And then we can go up to the temple area. And again, in the superficial subcutaneous compartment. So you can see that when we go insert the cannula, we are using the cannula number 22, and then go 3 lines going slowly, putting the product, small aliquot, along all the line of the treatment. So we go a little bit like retrogradely scatter the product. So it's about the same. And 2 sides, I will go a little bit faster. And after that, maybe 5 minutes, then we start with a fractional needling in these same patients. Oh, sorry. Then going with a RF. So we set this case is around 1.2 mm, and needle 25 small needling, and going scatter block by block, overlapping around 10%, not too much. Since there are some systems with the 2 pulses already fire in the system. So in terms of the fractional needle, the settings, the detail setting is still very variable amongst operators. Like practice say, the standard of the parameter is still not standardized, not so settled. Whether we want a skin surface, we're going into the rejuvenation or the fat killing procedure. So we just have to go in. In the area that we have the skip area, then I have to fill it all the places. Okay, then this is the result 3 months after the treatment. We're using, this is a double shot, and before and after. For the jawline here, you can see a little improvement and some of the volume up. The jawline is improving, and also on this right-hand side. This is also the fractional plus the PLA. You can see some case with the result a bit different. Some you have seen the contraction of the face for the PLA, and also the heat stimulation on top. And also this is also 2 pins, 2 shots after. So the take-home message is we can start the treatment from the deeper layers to shallow. We can do the multi-passes and multi-layers treatment. We can set the power, the level of the radio frequency and needle length according to the response in each sessions. PLL can be injected into the subcutaneous layer, scatter the product into small aliquot, scatter homogeneously in the tissue. So thank you for your attention.
Thank you so much for your wonderful presentation. Because Dr. Python is leaving, so any question to Dr. Python? Oh, yes, please.
When we do the PLA alone, and when we combine, we want the 2 factors, as I mentioned, the heat and the chemical that can stimulate at the same time. Before, I have been using the fractional RF, starting with the RF, and then inject. Somehow, the skin is quite red and too stimulated. So then we move to the injection first, and that PLA coupled with the lidocaine, so they numb all the face of the skin. Then we can go on top with the fractional needle. So they can combine these two effects in one session. But of course, in the safe way, we can separate the session into two times depending on what the patients want. Because the PRA, the stimulation is kind of a contract and a little self-stimulation from the collagen. But in some cases, we can see not too much different of the results. But when we combine the RF, the heating, we can show like the pore size and even from the roughness and acne scar as well improve quite a lot.
Yeah, so doctor, I am doing both the things. In India, Sculptra has recently been launched. So, we are more worried about the side effects. And if we combine both the treatments, the company may not support us saying that, we never recommended something like this. So still, if I do it at 15 days interval, still the results would be better. The PLA plus the micro needling at 15 days apart or 1 week apart. Would the results be better? I wouldn't combine only because of the, if anything goes wrong. The Sculptra people would say, why have you combined? Something like that to support us. That's the only way. So you could, if you could get similar results, your results were fantastic. So would you get good results if you combine one session of PLLA and microneedling at few days apart? Still you would get the results?
I think so.
Okay, thank you so much.
Thank you.
Okay, so because of time limit, let's move to the next speaker. There's an anatomist from South Korea, Dr. Kyu Ho-yi, Professor Kyu Ho-yi. He will bring us a needle RF and the chitosan combination for melasma treatment.
Thank you, Dr. Patrick. My pleasure, Faisal, Dr. Faisal. Full screen?
Yes. Maybe you don't need the stand.
Oh, okay. I stepped down. A little bit of, yeah. Oh, thank you. So today I'm going to talk about needle RF and skin booster. That's anti melasma formatting formulas in combination therapy for melasma treatment. So there are nowadays most of the needle RF device they come out with the needle RF, right, for treating the melasma, right? And I'm going to talk about what's the melasma, what's the pigmentation, and that kind. So sponsored by Bison, I'm going to talk about needle RF, which is Eladam, right? So the melanin, okay, is a good electron acceptor. It has a semiconductor property, meaning that they can be have a high conductivity and maybe a lower conductivity depending on the status that they carry, right? So there are human tissues, they have a conductivity. Some are high, some are low, okay? And melanin, it's pretty much low in the human body. And the reason that it gives a good effect with the needle RF is that they give heat and with the very low conductivity of the melanin, right? And so this is the melanin that has a Q-melanin monomer that has carboxyl group that's attached. When they are attached, and that is attached in a human form, so the melanin has a low conductivity. And when you make it pure melanin, it has a high conductivity. So that's why we call the melanin as a semiconductor, right? So RF energy effect in melanin production cell, okay? The heat itself. So there are certain level of the energy that suppresses the melanin production and degrades melanin, right? But if you go over too much of a high energy, it causes PIH, meaning that they stimulate higher production of the melanin. And when we use needle RF for the melanin treatment, it's supposed to be very steady level of energy that degrades the melanin production and return to the early stage of melanin. Okay, so this is the melanin stage. Stage 1, they're more in a lesser, darker color, but when they are in a later stage, stage 4, they are known to have, have the full-grown melanin, which is visible as a black color, right? So post-RF can suppress. Post, meaning that they don't reach to high level of energy, but rather they keep the level of energy very steadily, meaning that the temperature is quite steady, not going so far. So what the post-RF does is that they suppress the melanogenesis. And there are continuous type and post-RF. They have a modality that setting value that puts post or continuous. So when we are treating melanin treatment, we put them into post-RF, right? So RF, and RF, we use it for the rosacea or like a high vascular diseases too, because they have a selectivity in this coagulating the vascular wall. So post-RF are more selectively coagulating than the non-post RF. So this is one of the reasons that we use needle RF for not only the pore tightening or like a skin laxity, but we use it for melasma treatment or rosacea. Okay. So this is the direct current, and there's a RF electrical current that only covers, stimulates in the vessel wall. Okay. Thermal relaxation time. This is one of the concepts that we use for the laser treatment, but this also applies to RF too. So we don't hit too much of energy to overstimulate the cells or necrosis the cell. So a little bit different from the laser concept, but they do have a thermal relaxation time. So this is one that guides, and you let the treatment to be very safe, and this is something that we all need to know when we do energy-based devices. So continuous wavelengths that will cause, like a very high temperature or high energy delivery, but when it's post, you give a time to relax. So it's one of the concepts that we use in energy-based devices, right? So there are energy-based devices that gives, long pulse lasers. They are more of a continuous form that causes more of a heat accumulation. So when we use a long pulse laser, we can have accumulation of the heat, right? So what are the requirements of the longer pulse duration? It's all the energy-based devices, they have a different depth targeting, and also a lot of energy-based devices comes with the cooling, right? Cooling, and also when you want to deliver the energy very evenly, they need a suction actually for the needle RF. So nowadays they come out with the suction and cooling based needle RF, and this device is something that gives cooling and suction. Okay, so they have an improved effect by suction and cooling at the same time as the energy goes in, and they also gives 1 megahertz and 2 megahertz at the same time. 2 megahertz is not for melasma treatment, more of pore tightening, skin tightening, but they can deliver at the same time. Okay, so deeper penetration, because the needle, they go into deep, and the pain control, how do they do it? Suction. When they have a suction, it causes gate control theory. When they have a suction, they block the channel of the pain and reduces the pain sensation. Also, when they have a cooling, it will also is relevant to gate control theory. So what it causes, less PIH. So more controlled and suppress the melanin production. So this is what it does. They have a high watt maximum, but this is not for the melasma treatment, okay? 1 megahertz with the post is what we use for the melasma treatment, okay? So 1 megahertz is more for, you know, the melasma or like a basement membrane strengthening, while 2 megahertz is more of an intensive care for the local to the needle tip, okay? So this one, they have a vacuum pump, they suction, and they put the needle very equally in every part of the needle. If they don't have a vacuum, you are more likely to put needle deeper in the central area, the needles in the center. But this one, they put them very evenly. So this is non-even depths if you don't have a suction. So they have a power mode 1, 2, 3, 4. And when we use for the melasma treatment, we go with a pulse with a very low energy level, okay? So this is something that also you can use it for the body, like a fat reduction. So fat reduction, you go with 2 megahertz with the higher watts, okay? Cooling gas cartridge, they come out with the CO2 gas, which makes cooling in the surface, so lowering the downtime. This is one of the reasons that we can use it for the melasma treatment better than the other products. And vacuum cartridge, even depths of energy level delivered in all the surface area of the tip, okay? So how we do it? How we do it? Poor skin quality gets better, pigmentation. So we do the needle RF, okay? Then I put the skin booster, okay? Skin booster that is for melasma treatment, and that is Chitosan, okay? Why Chitosan is good in combination of energy-based devices is that it makes a very thin biofilm. Biofilm makes, they don't make a folliculitis. Infection, so needle RF, when the needle is going into the skin, they are prone to infection. And we see a lot of folliculitis after this kind of fractional laser or needle RF. And Chitosan is something that is made out of mushroom. We derive it from mushroom. And this is the one that has antibacterial and antifungal effect. And also they have evidence that suppresses MITF, okay? So nowadays, they came out with a very small size of Chitosan. We call it ideal size Chitosan. And they are smaller than a 500 Dalton. And that is why we topically use this product, but also it can be combined with the needle RF. So ideal size Chitosan dressing after microneedling or like an RF microneedling, it prevents dramatically the folliculitis occurrence, okay? So for every treatment of the needle RF, I topically use this Chitosan for preventing the folliculitis. And this Chitosan have a positive charge. And that is one of the reasons they have an antibacterial effect, which has a negative charged bacterial wall. And the Chitosan, when they go very smaller size, they are anti-inflammatory responses. They put more M2 macrophages compared to M1 macrophages. That is one of the reasons. And also they prevent the sebum secretion. Because when you stimulate these follicles, they can cause more of a sebum secretion. So they have a sebum absorption. And also, they make a really thin biofilm. This is why the Chitosan have been used as wound dressing. So all the time, we've been using Chitosan as wound dressing. We've been using it for plastic surgery in the incision line. But now, they come up with a very smaller size particle of Chitosan. they may just rubbing in is effective. But in combination of energy-based devices, they give a very good synergetic effect. So one side is Pitocin applied with the needle RF. The other side is non-Pitocin applied needle RF, okay? The downtime is much shorter because they have anti-inflammatory responses that also relates to the melasma, the PIH production. So this is how I use it in my clinic, needle RF, then Pitocin application, and it's a perfect combination for melasma treatment, not only for the melasma, but for the skin quality and preventing folliculitis and so on. Thank you so much. And this is my Instagram. Follow me, I will follow you back. Thank you.
Okay, thank you so much for the wonderful talk. So because of time limit, let me invite our next speakers, Dr. Crosot. Is that correct? I'm sorry. Okay, so you bring us that the HIFU versus the monopolar radiofrequency, how to choose and when to combine. Thank you so much. Thank you.
Thank you. I'm French, living in Belgium, so I'm dermatologist in Belgium.
Okay.
And I'm the vice president of the French Society of Laser in Dermatology. So the focus today is about HIFU versus monopolar radiofrequency. So we have two targets, two levels, and one shared goal. I have no disclosure for this presentation. And we all know that the skin laxity is one of the most frequent concerns we see, and many devices are available, and it's difficult to choose HIFU or monopolar radiofrequency, or both now because we have new devices. So that's the wrong question. The real question is what tissue are we treating? If we see the nomenclature, we have HIFU, so we have multiple devices, but HIFU also, it's ultrasound energy which creates focal thermal coagulation. Monopolar radiofrequency, so the most common is thermage, but we have also newer devices, and it's a current of radiofrequency which creates a diffuse thermal heating, and the chromophore is independent, so it's for all phototypes. So when we consider anatomy, we have two targets and two depths. For HIFU, we will treat on the SMAS, deep dermis, so it's very deep. For MRF, we will be more superficial. We will treat on dermis, but also fibrous septa. So what are the mechanisms of HIFU? So if we have a focal heating to 60 to 70 degrees. So we have thermal coagulation points. We can see them here. Epidermis spared, and we have a collagen denaturation, contraction, and remodeling. So it takes weeks, months to have the results. And we use several transducers from 4.5 millimeters, 3 millimeters, and 1.5 millimeters to reach this mass. It's a unique non-invasive device. So the mechanism, it's a thermal coagulation with localized hyperthermia at precise focal depths. And we have microthermal lesions. So look here, so in the treatment, you can see here we treat at 4.5 millimeters, and then 3 millimeters in the deep reticular dermis, and then 1.5 in mid dermis. So we have a structural tightening at deep anatomical levels. And the indications, it's moderate to severe laxity, lifting and contour definitions at brow, jawlines, and neck. So you can see here the focused ultrasound delivers the deep dermal layers, and you see the teeny points in the skin, which create a retraction then. Histological and clinical evidence, so we can distinguish the effect here on 4.5, but for body, for example, we can go deeper in the skin. also to 9 millimeters. And here it's a paper showing the results in vivo and on histological. So we have an extracellular matrix denaturation, fibroblast recruitment, collagen elastic neocollagenesis. So here you can see we have an 89 global aesthetic improvement, 84% of patients reported improvement, and 42 studies included with a good result. What about monopolar radiofrequency? So the mechanism is a radiofrequency current with a dermal heating up to 65 degrees. And we have a partial collagen denaturation with immediate contraction and dermal thickening. So we can see here the effective here. We don't have we have a coagulation, but we don't have an effect on the dermis. So we can treat upper mid reticular dermis, and we have a diffuse volumetric heating versus HIFU focal points. And the earlier onset is improved texture, elasticity, and skin quality. So you can see here the effect. It's like after if you put on a mattress and you will tend the tissue. So we have several devices here. You can see Thermage or Seleniu, or because in Belgium we don't have more devices. About histological and the clinical evidence, you can see here the result after 2 months, the improvement. So on the papillary dermis, upper reticular dermis, and we have more parallel collagen fiber arrangement. And at 6 months, you can see high collagen elastic fibers and collagen fiber density. So we have a clinical translation on the visible jawline definition and skin firmness. So we can see now how to compare the both devices. So neocollagenesis in each, but papillary dermis, upper mid, and deep reticular dermis for monopolar, and mid and deep reticular dermis only for HIFU. Here we have a comparative histometric analysis with a widespread neocollagenesis in the both papillary and reticular dermis and diffuse neoelastogenesis. And here with HIFU, it's targeted neocollagenesis and deep neoelastogenesis. Here it's you can compare it's an overview with the tissue visualization, because with HIFU you have ultrasounds to visualize. You cannot visualize with MRF. We can treat each phototype, so it's important. And the best indication, moderate to severe laxity for HIFU and mild to moderate laxity texture for MRF. And here it's also about the paper comparing the two. And we have here it's a randomized evaluator blind trial, MRF versus HIFU. For neck lifting, there's no significant difference between the both devices. And here at 6 months, another one on the face, there's no statistical difference in laxity, and patients are very satisfied. So, but perhaps the most important now, it's the new devices which combine HIFU and MRF. Why to combine? Because we can treat the several levels. And the texture also enhancement. So we can have a multi-layer collagen remodeling from superficial dermis to SMAS. And we can demonstrate outcomes. It's safe and well tolerated. We have an increased collagen fiber deposition on each multi-layer, enhanced tightening and lifting effect, and you can see the improved aesthetic satisfaction. In this paper, they combine both. So another paper about Asian evidence. So you can see it's a study design, retrospective single center with 56 patients, phototype 3 and 4, and majority Chinese and Indian. And we combine HIFU and MRF, and they have 86% of improvement, significant improvement, with transient mild erythema, but no serious effect, no burns, swelling, numbness, and paralysis. So it's important for aging consideration that we can both combine the technique. What about side effects? So for HIFU, we have a common effects, transient erythema, mild edema, pain during procedure, and tenderness. But resolutions, it's hours to days, for no intervention needed. Less frequent, we have focal bruising, mandibular ecchymosis, and temporary numbness, mild tissue swelling, 2-3 weeks spontaneously. You can see here a patient who was burned in the publication. And more rare, but significant, we can have nerve injury. We presented this case in IMCAS alert. And here it was a patient that I had after aesthetic treatment in an aesthetic clinic, and she had necrosis on the cheeks. I presented it also in IMCAS alert. For MRF, so the more common, it's a transient erythema, mild edema, pain during procedure. So it's important to prevent and to help the patients. And PIH, more frequent, it's Fitzpatrick 3 and 4 and 5. But we have hours to days resolution. If we consider MCAS alert, we have no paper published, no cases published about side effects with monopolar radiofrequency. And it's important to know that if patients have metal implants, so you have to avoid a pacemaker, cardiac device, and pregnancy. Of course, it's also a contraindication. About the safety of both methods, so first, it's important to know that you cannot treat periorbital area with HIFU, and don't forget to put goggles, but not metallic goggles when you treat with MRF. So it's important to respect the danger zones and to adapt to the phototypes. Results for both techniques, we have the same efficacy with a laxity, texture, and relachment and tightening, but it's important to know that it takes few days, months, weeks, so we have to wait. Here we can see some results with phototype 1 and 2 in Belgium. So here it's with radiofrequency, monopolar radiofrequency, but also on the eyes, eyelids. Another one. Here it's after 1 month, so we still have good results. So we can pass the procedure of HIFU. Here you can see results with HIFU. And here, if we compare the results with MRF and HIFU, we have the same results. So take-home message, differentiation. So HIFU works deep for the lift. It's for moderate to severe laxity. MRF works at the surface for the skin. It's to mild to moderate laxity. Combination is important. So in the future, I would enjoy to try the new devices, but we don't have in Belgium. Did you try? So it's a complementary depths, give multi-layer remodeling from superficial to deep to mass, and then safety first. So it's important to respect danger zone. So they are not competitor; they are complementary. Thank you.
Thank you. Thank you for your wonderful presentation. Yeah, we'll lead the Q&A session at the end of the session. Yeah, thank you. Well, let's welcome our next speaker, Dr. Wang Xiuhan. Dr. Wang is famous for his post-degree that is mechanical engineering and the medical doctor in his study. So today he'll bring us the talk about the advances in impedance control technology, improving safety and outcome in monopolar frequency. So this is a very unique way to deliver monopolar frequency. Thank you.
Thank you. Thanks for the introduction from the chair. Good afternoon, everyone. I'm Dr. Xiuhan Wang from Taipei, Taiwan. Today, I would like to share my topic on why the impedance control is essential for monopolar radiofrequency treatment and how it can affect the safety and the clinical outcomes. This is my information. My background combines dermatology with the electrical and the mechanical engineering. So I'm especially interested in the effect of what's the energy delivered by the device, and what's the final biological effect produced in the soft tissue. This is my disclosure. Let's begin from this very simple RF circuit. The RF circuit is composed by the RF generator, and the RF current may be transferred from the generator from the active electrode to the soft tissue, and then finally return from the return pad. So this is a very important question. Why same setting gives different outcomes? This is a very common question we face in daily practice. Actually, the variability can be noted from several points. For example, the patient tissue properties, and from different location size, and the contact quality, and the return electron pathway. So I want to give this concept of impedance control to reduce this invisible variability, because the same display setting not equal to the same biological or thermal dose. What's impedance? It means the total load seen by the RF generator. In other words, it means the total electrical load presented to the RF generator. Let's study this impedance circuit. The impedance can be composed by two factors. The first one is the local impedance, which is very important to the doctor because it can give us the information of the current density and the produced power. And the second part is the bulk impedance from the body. In fact, impedance is more than resistance because resistance is the real part of the impedance. It is also composed by the reactance. This picture tells us what's the process translating electricity to volumetric heating. We can see in this pathway, the final clinical endpoints can be determined not only the parameter we set in the device, but also the current distribution and the tissue conductivity. So the same machine setting produce vastly different heat levels. And from this concept, we can see the RF heat is inherently non-uniform and may create focal hotspots. So we should be careful when we conduct this treatment. In fact, the thermal effect of RF current can be induced by the current density, by the tissue conductivity, and the exposure time. So it's very complex. So why impedance matters? Because it can relate it to energy delivery, heat uniformity, and the heat safety, and the treatment reproducibility. So the impedance is the bridge between device settings and the biological heating. For example, the contact area is important because if with the poor contact, we'll have the very high current density, and the impedance should be very unpredictable, and we may get the final result with focal hotspots, and the patient will be burned. If we compare with the ideal contact, it's very different. This is a clinical case treated by me. The patient insists I have to treat her filtration. However, unfortunately, the filtration is an uneven area, and is not the common treat location by our treatment. So we can see the focal hotspot was noted, and the mild edema with a very tiny vesicle can be noted. So the current clouding is dangerous because even with the modest current clouding will cause very significant rapid thermal spikes because it is a nonlinear amplification of the temperature rise. even we only have a very small change of the contact area, the change of the temperature will be amplified nonlinearly. And the poor contact can determine different the resistance or the impedance, and will change the current density. So it's very dangerous. So what's the factors influence the impedance? Several factors should be noted. First, the patient factors such as hydration. With good hydration, we can see the transmission of the energy will be smoother. And the interface factors are also important, such as the contact area. And the thermal factor is also important, such as temperature. For example, we have to conduct the monopole radio frequency with multi-pass treatment. With the multi-pass treatment, we can gradually increase the temperature, and it will decrease the impedance. And finally, the circuit factors are also important. For example, return path precision. So impedance is a dynamic property of the patient device circuit system. It is not a very simple number. And the return electrode is important. We should not think of as a very simple accessory. No, it's a very important part of our circuit. Because the placement of the return path will shape the current pathway. For example, this is now another case. This patient insists me to treat her with the very close placement of the return path, because something tells her this will produce larger energy for better effect. Unfortunately, after treatment, we can see the path edge burn. Even the treatment course seems uneventful, but this tiny blister can be noted. Why? Because the return electrode distance will shape the current pathway and the energy distribution. It will affect the efficacy and the safety. If we place the return path closer to the active electrode, we will have higher current density and with shallow penetration. And if we place farther, we will have low current density and with deep penetration. So what's the best operation? So I conduct this numerical simulation. We can see in my study, we can see the impedance variations will gradually decrease when we increase the distance. And we have to balance the safety and efficacy. So for every unique modality, we can to calculate the optimal distance of the return path. For example, for the thermal-like system with a single return path system, maybe the optimal distance I suggest is about 0.4 to 0.45 meter. And what happens if we don't practice the impedance control? We will have the under-delivery, over-delivery, and the unstable delivery, and we may have the impedance local hotspots due to the current crowding. So I have to emphasize again that displayed energy may not equal biological effect thermal dose. And the impedance sensing and monitoring is important. Everything begins from measurement. If we can measure the impedance, we can interpret the coupling and the tissue load correctly, and we can trigger feedback and safety. So measurement is the prerequisite for feedback-guided control. In fact, when we review the previous data or database, we can see some patents focus on this issue. I found two patents. both of these patents focus on 3 strategies. They measure the tissue and the system impedance, and they adjust the matching network elements and the improving energy transfer efficiency and the safety logic. Besides, we can combine impedance matching and the real-time calibration to decrease the variability for better treatment efficacy and the safety. First, I will explain what's the impedance matching. Impedance is a key determinant of energy transfer efficiency. If the system without good impedance matching, the efficiency transfer will be decreased. And the impedance mismatch is very common, not only unique to RF circuit. We can see the RF system, ultrasound, and the laser, and the microwave, and the mechanical wave, all these systems will have the impedance mismatch and the energy reflection phenomenon. For example, in the ultrasound system, the impedance mismatch will cause the reflection of the energy, and we use this phenomenon to have the 2D ultrasound images formation. And what happened without impedance matching? In this simplified model, if we don't have a good impedance matching procedure, the reflected energy will be very high, and theoretically, the power transfer efficiency is about only 56%, so it is very low. And these pictures demonstrate the same concept with more information. We can see if the patient's impedance changes, the reflect energy will be also changes at the same time. So how to perform the impedance matching? This is one of the procedure I suggest. We can use the shunt capacitor and the series inductor, and to change the VSWR to about 1 and 2 for better impedance matching. And the key patents on dynamic RF impedance matching tell us.
It's that time? Yes.
Tell us with this procedure, we will have maximized the transfer efficiency. This is the hardware design. And another smart strategy is real-time impedance calibration. You can detect the impedance and change the voltage to maintain the stable output power with a good hardware design. And we can compare these two systems. They focus on different goals. Finally, I will give the summary. The RF treatment are composed by many factors. It's not only the device setting, it's also on the impedance, coupling, current distribution, and the final thermal effect and safety. Impedance is the bridge between the device setting and the biological heating. And for the doctor, we can adjust several determinants for impedance, such as contact area, current density, interface quality, and the return electrode circuit. So we can see the 4 pillars of dynamic impedance is very important. And finally, we have to shift our mindset from fixed energy settings to feedback guided RF delivery. Thank you very much.
Thank you so much for your very informative the talk. And because of time limit, we have to end this session. But after Dr. Shalini's talk, so Dr. Shalini, thank you. Thank you so much for being. Okay, so today she'll bring us the triple-layer energy-based rejuvenation for structural skin longevity, a prospective 3-dimensional quantitative study in early aging cohort with 1 month's objective outcomes. Thank you.
Thank you so much. Good afternoon, everyone. I'm Dr. Shalini Piantanapak, an aesthetic doctor from Thailand. Today, I would like to discuss about our experience with a multi-layer approach to facial rejuvenation in the topic triple-layer energy-based rejuvenation. Because facial aging occurs at multiple tissue layers, so how many Many treatments target only a single layer, so can we achieve better outcome by treating multiple layers simultaneously? Based on this idea, we developed the concept of structural skin longevity by targeting different tissue depth at the same time, and we aim to create a more comprehensive rejuvenation effect. So, we enrolled 30 patients with early sign of facial aging, and patients were evaluated at baseline and 1 month, and we used 3D imaging and skin analysis system to objectively assess the treatment outcome. Because each technology targets a different layer, so microfocus ultrasound provides lifting, monopolar RF induces dermis tightening, and microneedle RF improves skin quality. So that is 3 layers and 1 strategy. And all treatments were performed in a single session. We start with microfocus ultrasound, and then monopolar RF for dermal tightening, and finally microneedle RF for superficial remodeling, minimal downtime, and well tolerated. Now let's look at the clinical outcome. I will share several representative cases comparing baseline and 1 month after treatment, but please note that the results continue to improve up to 3 months. Let's start with our first representative case. First, we will evaluate jawline and facial contour. Comparing the baseline and 1 month image, we can see a mild improvement in jawline definition. And from the side view, the facial contour appear more defined with improved jawline definition and reduced facial sagging. And in this video, further demonstrate increased tightness of submental area and a more defined jawline. Now let's look at volume analysis. In this map, blue area represent volume reduction or tissue contraction, and the most prominent volume reduction is observed in the submental area. And this suggesting significant fat reduction in the submental area. And quantitatively, jaw and submental volume decreased by 4.36 ml. And the vector map also demonstrates tissue lifting, particularly along the lateral jawline. Now let's move on to skin quality outcome. In this case, we can see that pore size was significantly reduced after the treatment by 19.5%. We can see smoother and more even skin texture in post-treatment image. And also wrinkle improved by about 35%, with significantly reduced in the image. And subdermal pigmentation was significantly reduced after the treatment, with the mean score decreasing from 18 to 6. And UV imaging show fewer pigmentation spots and more even skin tone. And ultrasound imaging show an increase in dermal thickness, about 9.4%. This suggests increased collagen production within the dermis, leading to improved skin quality and strength. And now moving on to case 2. From the frontal view, there is a clear reduction in submental fullness with improved jawline definition. And this video comparison shows visible tightening, particularly in the cheek and the submental area. And from the side view, enhanced facial contour, improved jawline definition, and reduced facial sagging can be clearly observed. And this video confirms a reduction in submental fat together with an overall lifting effect. Next, let's review the volume analysis. In this image, we can see the more significant volume reduction in the cheek and the submental area. Quantitatively show that jaw and submental volume decreased by 13.6 ml. And now let's look at the skin quality outcome. In this case, post-treatment image show reduced in pore size and improved skin texture. And facial wrinkles were significantly reduced with a 7.7% improvement from baseline, while skin redness decreased by 50%, leading to a more even and smoother skin tone. And subdermal pigmentation in this case was markedly reduced after the treatment, with a mean score decreasing from 9 to 1, about 88% improvement. And ultrasound imaging showed an increase in dermal thickness, also indicate increased collagen production in the dermis. Taken together, these two cases demonstrate significant improvement in facial contour, facial lifting, and skin quality. And beyond these two representative cases, similar improvements were consistently observed across multiple additional patients. In this case, we can see improved facial contour, better jawline definition, and reduced facial sagging. And we can see improved jawline definition in this video also. And volume analysis confirmed reduction in the jaw and the submental region, supporting the contour change observed clinically. And skin quality improvement were also reproducible, including reduction in pore size, reduction in wrinkle depth, reduction in redness, and also reduction in subdermal pigmentation. And in addition, ultrasound imaging consistently showed increased dermal thickness, suggesting collagen remodeling across the case. And this finding indicated that the treatment effect was not limited to a few select cases, but was consistently observed across the multiple patients. Overall, this finding demonstrates consistent improvement across both skin quality and facial structure, and we observe measurable improvement in increasing in dermal thickness, reduction in wrinkle depth, reduction in pore size, reduction in pigmentation and redness. And more importantly, this objective change translates into visible clinical outcome, including significant lifting effect. We can see support by volume reduction, tissue contraction, and upward lifting vector seen on 3D analysis. And second, we see facial contour became more defined with a slimmer and more scalp appearance. And third, jawline definition improved consistently through reduction of submental and lower facial volume. Together, these findings suggest improvement not only in skin quality, but also facial structure. So, treating multiple layers together result in simultaneous improvement in lifting and skin quality, and this may represent a coordinated regenerative response. And so, what does this mean in clinical practice? First, in younger patients, early intervention may help delay visible structural aging. Second, a multi-layer approach may provide a non-surgical option that addresses both lifting and skin quality simultaneously. And third, the treatment can be complete in a single session with minimal downtime, which aligns well with current patient expectation. And of course, longer follow-up is still needed to confirm long-term outcome. And to conclude, there are three key messages. First, facial aging occurs across multiple tissue layers. Second, treating multiple layers together leads to coordinated improvement in skin quality and facial structure. And third, structural skin longevity concept may be a new approach to treating and preventing facial aging. Thank you very much.
Well, congratulations on your very innovative combination and a wonderful result. Thank you. So I think because of time limit, we just only allow one question. And we only have half of the speakers still here. Yes, please. Yeah, please let us know your name and where you're from.
Hello, I'm Dr. Dion. I'm from Greece, Europe. I just want to ask if all these modalities were done in the same session, so monopolar RF, HIFU, and microneedling RF, same day.
Yes, actually, the treatment you can perform in the one session in the same day. We start with microfocus ultrasound, HIFU first, and then do the monopolar RF, and finally with a microneedle RF. Yes, you can do at the same time. No, yes, because I usually do with my patient. Thank you.
Well, thank you so much for your attention, and it's very late now, and appreciate your attendance till the end of the day. And thank you. I look forward to seeing you tomorrow. Thank you. So I'd like to invite the speaker here for the group photo.